Buenos días a todos, son las 9 de la mañana en la ciudad de Bogotá. Bienvenidos al segundo Ateneo Javeriano de Patología. El día de hoy nuestro tema serán lesiones fusocelulares en la glándula mamaria. Gracias por la asistencia. Les recuerdo que tienen el box para que realicen sus preguntas durante la charla y al finalizar, si queda algo de tiempo, procederemos a realizárselas a nuestra invitada. De otra forma, también los que no tengan la oportunidad de ver la presentación en vivo, la presentación queda en el canal de la Facultad de Medicina de la Javeriana para que lo puedan divulgar con residentes, colegas, para que lo puedan ver posteriormente. I'm going to introduce, so it's a pleasure for me to introduce to you Dr. O'Connor. She's an associate professor, breast pathologist and cytopathologist. She works at the University of North Carolina in Chapel Hill, USA. She was one of my mentors when I was doing my training there. Besides that, she's also one of the sweetest people I've ever met. So, hi, Dr. O'Connor. Thanks for joining us.
Hi. Thank you, Dr. Rubio, for that nice introduction. And thank you, everyone, for attending. I hope this lecture is helpful. So I will go ahead and get started. We're going to talk about spindle cell lesions of the breast today. And I have no disclosures to report. So as far as the outline, we're going to have a quick overview, talk a little bit about metaplastic carcinoma, because it does come up in the differential for spindle cell lesions of the breast. And then we'll talk about bland appearing spindle cell lesions, the benign ones, and then the ones that are considered locally aggressive, and then a couple of lesions that are low grade, but they do have some metastatic potential. And then we'll talk very, very, very briefly about primary sarcomas. So today we're going to talk about lesions that consist entirely of spindle cells. So fibroepithelial lesions are not included in this presentation. Those are very important, though, and they do come up in the differential for some of these lesions, and they deserve a whole separate presentation, though. So primary sarcomas of the breast are extremely rare. High-grade malignant spindle cell lesions usually represent metaplastic carcinoma or the stromal component of malignant phylloides tumors. And the vast majority of this presentation will address a selection of the more bland appearing spindle cell lesions, just because the primary sarcomas are so exceedingly rare. So bland appearing spindle cell lesions do range from reactive lesions to those that are low grade and have some metastatic potential. So it's really important to differentiate between the benign lesions and the ones that are potentially aggressive. And sometimes distinguishing among these lesions can be difficult because there is quite a bit of morphologic as well as immunohistochemical overlap. So a little bit about metaplastic carcinoma. So there are several histopathologically distinct patterns, and these are the ones that are recognized in the most recent WHO classification. So the low-grade adenosquamous carcinoma, fibromatosis-like metaplastic carcinoma, spindle cell carcinoma, squamous cell carcinoma, metaplastic carcinoma with heterologous mesenchymal differentiation, and then the mixed metaplastic carcinomas. So the ones that come into the differential diagnosis for spindle cell lesions are the fibromatosis-like and the spindle cell carcinoma. So spindle cell carcinoma must always be excluded when there is an atypical spindle cell neoplasm, whether it's high grade or low grade. Spindle cell carcinomas are also quite rare, as about up to 1% of invasive breast carcinomas, and they consist of either pure spindle cells or predominantly spindle cells with a minor glandular, squamous, or heterologous component. And most often you see the spindle cell carcinoma paired with squamous cell carcinoma. And the carcinoma can range, as I mentioned, from cytologically bland to markedly pleomorphic. So it does enter the differential diagnosis for bland and malignant lesions. And these are almost always negative for ER, PR, HER2, although there are rare exceptions. So there are different growth patterns of spindle cell carcinoma, just like there are for all spindle cell lesions of the breast. And those include fascicular, fasciitis-like, storiform, haphazard, and the mitotic rate can be quite variable. They usually are infiltrative, which can help with the differential with some of the other, with some of the mesenchymal lesions of the breast, but some do show a pushing border, which makes them look a little bit less malignant. So these are just some examples from Dr. Schnitt's paper. And here you can see just these interlacing fascicles. And in the middle here, there are a couple of mitotic figures, and the mitoses help with the differential. This one is more fasciitis-like. It even has some myxoid stroma, which you often see in nodular fasciitis. And then this one clearly has epithelial differentiation. So that alone would tell you that it's not one of these other spindle cell lesions that we're going to discuss. So fibromatosis, like metaplastic carcinoma, also enters the differential diagnosis in the more bland spindle cell lesions. It consists of a proliferation of low-grade, cytologically bland spindle cells, and as the name suggests, it looks very much like fibromatosis. They often do have squamous or glandular elements, but they may comprise less than 5% of the tumor, so especially on core biopsies, you may not sample the epithelial component. So this is an example of fibromatosis like metaplastic carcinoma. And as you can see, especially at low power, it looks very bland. In this illustration, you see infiltration into the surrounding breast tissue, particularly here into fat. And as you can see, it's cytologically bland. And in this one, you actually have a mixture of spindle to somewhat plumper round to oval nuclei. But as you can see, it's very bland and it looks very much like fibromatosis. And these are just a couple of other examples. In about 2/3 of cases, it's going to look infiltrative on gross examination. And you can see here, some of it looks a little bit more well circumscribed, but then you have it infiltrating into the surrounding benign breast tissue. And this one is a little bit more bundled. So you have just disorganized bundles of spindle cells, but again, they look quite bland. In this corner, you can actually see an epithelial component. So again, the presence of an epithelial component immediately lets you know that this isn't one of the other spindle cell lesions that are in this presentation. So this is just a higher power of the area that had the epithelium in it, and this is just a cytokeratin, just confirming that there is an epithelial component. Okay, so bland appearing spindle cell lesions, and first we're going to talk about the benign and locally aggressive lesions. So this is a chart that was in this paper by Magro and colleagues, and there are a bunch of different ways to organize the bland-looking spindle cell lesions of the breast. In this paper, they did arrange them by reactive versus benign versus locally aggressive and metastatic potential, which is the way I have arranged them in this presentation. And we're not going to be going through all of these. But the ones we will be looking at today are the ones that I've highlighted here. All of these tumors can occur in the breast, rarely, but they look exactly like they do anywhere else in the body. So we're not really going to talk about these except for the solitary fibrous tumor, because more so than most of these, it enters the differential diagnosis for some of these other entities. So, a case we had at UNC, we had a 70-year-old female. She had a history of left breast invasive ductal carcinoma that was diagnosed in 1992, and she is status post bilateral mastectomies, and we're seeing her about 20 years later. When she had her mastectomies, they also did lymph nodes, and they were negative. So 20 years later, she noticed a small soft lump on the left chest wall, and it was at the mastectomy site. And ultrasound showed a 2.2 centimeter oval, circumscribed, parallel, homogeneous solid mass. So all those words, those ultrasonographic words used to describe this mass are suggestive of a benign mass, with it being circumscribed and parallel. So this is our core biopsy, and as you can see, it consists completely of spindle cells, and there are nice uniform ovoid nuclei. You can see some slightly dilated vessels in here, and some of them even have maybe the suggestion of sort of a staghorn configuration. And it has a vaguely storiform architecture. It isn't well developed. So we did immunohistochemical stains, and the spindle cells and the blood vessels were diffusely positive for CD34. CD31, however, was just positive in the blood vessels. So that lets us know that it's not a vascular lesion. And the spindle cells were also positive for BCL2, estrogen receptor, and CD99. They were negative for smooth muscle actin, desmin, and S100. And although desmin is usually positive in myofibroblastoma and smooth muscle actin is positive in about half of cases, we still thought that the overall findings, as well as the findings on ultrasound, favored the diagnosis of myofibroblastoma. So we did sign it out that way as a bland spindle cell lesion, favor myofibroblastoma. And there are single reports in the literature of myofibroblastoma arising at the surgical site after breast cancer excision or even after radiation therapy. So then we got the excision specimen, and overall the lesion measured 2.5 centimeters. It was very well demarcated, as you can see along here. And it again shows these really nice ovoid nuclei that are very uniform. There are visible nucleoli, but they're not terribly prominent. We did, however, see up to 4 mitotic figures per 10 high-powered fields. So we repeated some of the immunohistochemical stains and then ordered a few. And the tumor was positive for CD34 again and BCL2, but we also did a STAT6, which was positive. And it was focally positive for smooth muscle actin. It was negative for desmin, cytokeratins AE13 and Oscar, S100, HMB45, and melon-A, which also rules out melanoma. And again, the blood vessels were positive for CD31 and ERG, but the tumor cells were not. So at this point, we re-diagnosed it as a solitary fibrous tumor. So solitary fibrous tumors usually occur in the pleura, but they can arise virtually anywhere in the body. About 25 cases have been reported in the breast, so it is unusual, but it does happen. And it does have overlapping features with myofibroblastoma. However, it is characterized by this NAB2 STAT6 gene fusion, which is highly specific for solitary fibrous tumor. And luckily, we have this STAT6 immunohistochemistry, so we don't have to do the FISH. And the STAT6 is not completely specific, but if you have diffuse strong nuclear staining, then it is a reliable surrogate for the gene fusion. And with that diffuse strong nuclear staining, it is specific for solitary fibrous tumor. So most of these are considered histologically benign because, as you saw, it had, very uniform, small oval nuclei, and it doesn't have the appearance of being malignant. But they can metastasize in up to 25% of cases from all sites. And a study evaluating 79 patients did develop a risk stratification scheme. And this depends on looking at the age, the tumor size, the mitotic count, necrosis. And it puts it into classes that help predict whether there will be a recurrence or metastasis. And this would not be all that helpful in the breast, though, because they are so rare. But there is this classification system out there that can help determine risk if you did happen to have one of these tumors. So on to another one. This is the most common spindle cell lesion that we are going to talk about today. It's an incidental finding in about a quarter of breast biopsies, so we do see it all the time. It tends to be most common in premenopausal women, but the age has ranged from 3 years of age to 70, and it is also a frequent component of gynecomastia in males. And the tumor-forming patch is seen almost exclusively in women, so we don't generally see that in the male breast. And when symptomatic, which it usually is not, it presents as a firm, non-tender, unilateral mass. So as far as imaging for the tumor-forming patch, it tends to show a well-circumscribed round to oval density without calcification, and on ultrasound, a solid hypoechoic mass. So the findings are similar to those that you would see for a fibroadenoma in the tumor-forming patch. So grossly, with the tumor-forming patch, it's also circumscribed, it's non-encapsulated, and they have been reported up to 15 centimeters in greatest dimension. And they tend to be homogeneous or lobulated on cut surface, but occasionally you will see cysts, and they can be up to 1 centimeter. A minority of them are circumscribed, but also nodular, and you do not tend to see any hemorrhage or necrosis unless, of course, there had been a previous FNA or core needle biopsy. So this is just an example of how they appear grossly. This one's in the photos, at least, these are both quite yellow, but this one is very homogeneous, and as you can see, well circumscribed. This one's also well circumscribed, but more lobulated or nodular. So it can occur as an isolated mass, but it also coexists with pretty much any breast lesion. And it seems to occur more commonly with columnar cell changes. And what you see are slit-like anastomosing spaces. I'm sure anyone who's done breast pathology has seen this. And the spaces are lined by flat, elongated myofibroblasts, and it tends to be separated by bands of eosinophilic hyalinized tissue. And the myofibroblasts show scant cytoplasm, and they are very bland appearing cytologically. It usually involves the interlobular stroma, but it can also involve the intralobular stroma. And when it's associated with the columnar cell changes, it does tend to be intralobular, so it's kind of surrounding the columnar cell change within the lobular architecture. So this is a really nice example that we had where you can see these very nice slit-like spaces, and obviously it's called pseudoangiomatous because it looks like small vessels, and but instead of these being endothelial cells lining the spaces, they are myofibroblasts. So this is just an example of fascicular patch, and we do see this every once in a while. So you get it. It's more cellular than the normal usual type patch, and you get distinct bundles of the myofibroblasts, and sometimes you'll even have more collagen in between the bundles, so they are separated by collagen, so it can look even more fascicular than this. And in the mass forming patch of the fascicular type, the differential diagnosis is myofibroblastoma. And there is some thought that PASH and myofibroblastoma may be in a spectrum of the same lesion. So myofibroblasts in general, and this is true for all of the myofibroblastic lesions we're talking about today, show strong reactivity for vimentin. That's not surprising. And CD34 and BCL2 are positive in a majority of the lesions. They're negative for cytokeratin and vascular margins, which helps with the differential with carcinoma and with hemangiomas or even angiosarcomas. Sometimes they are reactive for PR, but ER is usually negative, and they show variable reactivity for actin, desmin, and calponin. So no treatment is required unless it's mass forming and it's large or it's uncomfortable for the patient. And ipsilateral recurrences have been reported, but they're quite uncommon. And when they do occur, they still behave in a benign fashion. So they're just managed again with re-excision. So PASH has absolutely no potential for metastasis. So myofibroblastoma was historically thought to occur more frequently in men. However, a greater number of them have been identified ever since screening mammography was instituted. So now they appear to occur with equal frequency in both men and women. And they tend to be more common after 50 years of age, unlike PASH, which is usually a little bit younger. So on mammography, again, it's a homogeneous, lobulated, well-circumscribed. It lacks calcifications, and just like the tumor-forming PASH, on ultrasound, the findings are suggestive of fibroadenoma, and they have been reported up to 12 centimeters, but they tend to be pretty small overall. Most of them are smaller than 4 centimeters, and the average is about 2 centimeters, so most of them are not large. They are circumscribed and rubbery, and they tend to be gray-white uncut surface. And one thing that can help you on the gross examination is that you can see areas of fat within the myofibroblastoma. It does like a true capsule. On gross examination, it can kind of look like it has a capsule because it can form a pseudocapsule that just consists of compressed breast tissue around it. So this is an example of a myofibroblastoma, and as you can see, it's lobulated, whereas the tumor-forming PASH tends to more often not be lobulated. The myofibroblastoma is usually lobulated, and in this one, you can't really see areas of fat, but sometimes you can. So the myofibroblasts are very bland appearing, uniform, slender, and they tend to be arranged in short intersecting fascicles, and they can have a somewhat storiform appearance. And you get intervening thick bands, and the collagen tends to be very brightly eosinophilic. You do not see atypia, or if there is atypia, it's minimal. And mitoses are uncommon. Rarely you will see up to 1 to 2 mitotic figures. So that was kind of, in the case I presented at the beginning, that was a hint right away on the excision where we had up to 4 mitotic figures per 10 high power fields, at least focally, that it might not be a myofibroblastoma after all. And then of course the STAT6 helped with that. Fat cells are an intrinsic component, so you almost always see fat cells, even if there's not enough for you to see it grossly. You almost always see them microscopically, and that is one of the defining features of myofibroblastoma. And it tends to have expansile growth, and it usually does not contain entrapped ducts, but there is a rare infiltrative variant that has been identified. So sometimes there is some entrapment of the ducts and breast tissue at the edges, but most of the time it just has a pushing border. So this is a nice one we had where you can see how well circumscribed it is, and then you see the fat cells distributed through here. And again, you can see the adipocytes here. And this one has a pretty haphazard arrangement, but it is short fascicles rather than kind of long sweeping fascicles. And you do see the collagen is not as evident in this one, but you can see this brightly pink collagen kind of distributed throughout in this one. Sometimes, and we'll see some other examples, you do get more thick collagen bundles. And in this case, it's not really showing that kind of whirling. So this one doesn't really have a well-developed storiform appearance. So myofibroblastoma, so pretty much all myofibroblasts are immunoreactive for CD34, BCL2, CD99, and vimentin. Myofibroblastoma is often positive for Desmond, and as I mentioned before, about 50% or so smooth muscle actin, and focally for H-cal-Desmond. One of its unique features is that it is almost all cases are positive for estrogen receptor and progesterone receptor, and they're pretty diffusely positive. So in about 70 to 90% of cells. So almost all cases and almost all cells. So that can be very helpful in the differential from other lesions. So it's negative for cytokeratins, S100, and myoepithelial markers. And if need be, generally you can diagnose myofibroblastoma based on morphology along with immunohistochemical stains. But if need be, there is a 13q14 deletion that can be seen by FISH in about 70 to 80% of cases. So these are some of the immunostains that we did, and as you can see, CD34 is diffusely positive, BCL2, ER, Desmond, and in this case, there were just scattered cells that were positive for smooth muscle actin. Most of these are actually vessels, but a few of the tumor cells stained, but it was mostly positive, mostly negative. So there are variants, and we'll take a look at these just so you know all the different ways that a myofibroblastoma can appear. So this is a collagenized one, and essentially it just looks like the usual type myofibroblastoma. You just get much more collagen and much thicker bands. And in cases like this, it can even look like fascicular pash. And that's why fascicular pash and myofibroblastoma can be in the same differential diagnosis. In this case, it has a more epithelial appearance where you have more cytoplasm, but the nuclei are still oval and they're pretty uniform. And in this epithelioid type, you have an alveolar arrangement of the groups. Here, and I've never seen one like this, but in this epithelioid type, you actually have a pattern that looks like lobular carcinoma. So in this case, lobular carcinoma would be in the differential. It isn't usually in the differential for spindle cell lesions, but for this particular type of myofibroblastoma. So luckily, lobular carcinoma is strongly and diffusely positive for cytokeratin. So that would help you distinguish. This is just a more cellular one, which the example that I showed of our case was more cellular like this, where you don't have as much collagen. And sometimes you'll have whole fields without collagen. So you just have more of these kind of smaller areas with the brightly pink collagen. And then this is an infiltrative one. Fat, as I've mentioned before, is part of a myofibroblastoma. But in this case, what they're illustrating is the myofibroblastoma actually infiltrating around fat within the breast. And in this one, they are actually entrapped benign epithelial components. But this is unusual, but it's good to know that you can get these infiltrative myofibroblastomas, and it does not make them malignant. And then this one is really nice. It's a palisaded or schwannoma-like. I've also never seen one of these live, but as you can see, it looks very much like Verrucae bodies. But again, it's easy to distinguish this from a schwannoma because it would be negative for S100, often positive for smooth muscle actin, but you could also use Desmond. So the differential diagnosis, and again, for most of these lesions, metaplastic carcinoma is part of the differential diagnosis. It tends to be more cellular, and it will have frequent mitoses usually. And as I mentioned, the myofibroblastoma usually only has, if any, mitotic figures up to about 1 to 2. And nodular fasciitis and fibromatosis also contain myofibroblasts, but fibromatosis tends to be stellate and infiltrative pretty much all the time, whereas most of the myofibroblastomas are going to be well circumscribed. Nodular fasciitis is typically well circumscribed, but it can entrap breast elements and appear infiltrative at the border. Fibromatosis shows abundant collagen similar to myofibroblastoma, but the spindle cells tend to be arranged in these long sweeping fascicles rather than seeing the short fascicular clusters that you see in myofibroblastoma. And also the plump myoid type cells and the inflammation that's characteristic of nodular fasciitis is not seen in myofibroblastoma. So no recurrences have been reported. So myofibroblastoma is considered a benign lesion, and almost all are managed adequately by excisional biopsy. And if you do see one on a core biopsy, though, complete excision is recommended. But generally, you don't need any more treatment than that. So nodular fasciitis, another myofibroblastic lesion, it is uncommon in the breast, but it occurs. And it can occur in the subcutaneous tissue or within the main parenchyma of the breast. And it often presents as a rapidly growing mass. So it is concerning for the patient and for the clinician. But it tends to be painful or tender, which carcinomas usually are not painful. It often disappears spontaneously within a few months. On mammography, again, like several of the other lesions, it tends to mimic a fibroadenoma. But as I mentioned, sometimes it can entrap breast tissue at the edges, so it can simulate an invasive carcinoma on mammography. It's unencapsulated, but usually pretty well circumscribed. And it looks pink to gray on cut surface, but can also appear mucoid because it often has a myxoid component. So as I mentioned, generally well circumscribed, but can show some what appears to be invasion at the edges, usually focally. And the cells are generally a little bit more plump than some of the other lesions we're looking at, but they also tend to be arranged in short fascicles and whorls like you see in a myofibroblastoma. The stroma is typically fibrous or myxoid. Often you do have a myxoid component. And you've probably heard that it looks like fibroblasts growing in tissue culture because it can be somewhat haphazard. And a couple of the features that are very helpful in making the diagnosis is seeing extravasated red blood cells and also inflammatory infiltrates that are admixed within the entire lesion. And in this case, mitotic figures are easily identified, and they may be numerous, but you do not see nuclear atypia, and you usually do not see necrosis, which helps you know that even though you're seeing all these mitotic figures, that it's not a malignant lesion. And again, you can entrap breast tissue at the edge. So the spindle cells express smooth muscle actin, but it may be focal. Desmond is occasionally seen, but again, it may be focal. So neither of those may be positive on a core biopsy. In this case, and this is one of the things that differentiates it from the other lesions we've looked at, is that CD34 is negative. And also, if you're not sure of the diagnosis based on the morphology and the immunohistochemistry, you can use FISH to detect a USP6 rearrangement. However, about 8 to 9% of nodular fasciitis cases do not demonstrate this rearrangement. So if you have a classic nodular fasciitis and it's negative for the USP6, you would still diagnose nodular fasciitis. So if it has classic features, you probably don't even need to do the FISH. So this is an example that we had, and it's relatively well circumscribed, but you can kind of see it kind of moving out into the fat at the edges. And here you can see that even in this one field, there were 4 mitotic figures. But even though the spindle cells are kind of more plump and look a tiny bit more concerning than some of the other spindle cells we've seen in some of the other lesions, they're still quite uniform. You can see some nucleoli, but they're not macronucleoli. And you tend to see the inflammation dispersed throughout the lesion. So these will often spontaneously regress. However, because they tend to present as rapidly growing masses, it's very concerning. So they do end up with biopsy and even sometimes excision. And if it does end up being excised, local excision is adequate treatment. These are benign lesions. So the differential diagnosis includes fibromatosis, which we'll talk about when we talk about fibromatosis next, and of course, metaplastic carcinoma. As usual, the myoepithelial or epithelial markers such as P63, pancytokeratins, or high molecular weight cytokeratins are positive in metaplastic carcinoma, and they would not be positive in nodular fasciitis. Inflammatory cells that you see in nodular fasciitis, you don't generally see in metaplastic carcinoma. And nodular fasciitis is non-invasive, even though you may see some entrapment at the edges. So fibromatosis, unlike the lesions that we've talked about so far, is considered a locally aggressive lesion. It does not tend to metastasize, but it does recur. It can occur at any age after adolescence. It tends to occur most commonly between the ages of 20 and 40. Rarely, breast fibromatosis is also seen in men. And it is also rarely associated with familial adenomatous polyposis. And we'll talk a little bit more about that. And sometimes it appears that it's associated with trauma, but other times there is no history of trauma. So the role of trauma is controversial at this point. So it does tend to present as a firm, palpable mass. And because it is infiltrative, it can cause cutaneous or nipple retraction. And on mammography, it may be stellate, so it can often look like a carcinoma. It can also cause architectural distortion rather than causing a stellate mass, but it can look like a carcinoma. And generally, you don't see calcifications associated with it. So grossly, just like you see on mammography, it tends to be ill-defined or stellate, and it can be quite suggestive of invasive carcinoma. And it tends to be white-gray on cut surface, but it has a very dense scar-like firm consistency. And it can range up to 10 centimeters, but it tends to be on the smaller side at around 3 centimeters in general. So these are a couple of examples. So this one is really has a nice stellate configuration, and on gross examination, and with it being a very firm mass, you would probably think this was a carcinoma, and this one possibly too. Here it's more well circumscribed and rounded, but even so, you can see where it's infiltrating into the breast, at least on one side of the lesion. So fibromatosis, unlike most of these other lesions that we've looked at so far, tends to have long sweeping fascicles of myofibroblasts instead of the more kind of short whirling ones that we see with some of the other lesions. And it almost always infiltrates into the surrounding breast parenchyma. And it tends to be less cellular, at low to maybe focally moderate cellularity. And you do see collagen intervening among the myofibroblasts. And the spindle cells have scant cytoplasm. The chromatin tends to be pretty open. And the nucleoli tend to be inconspicuous. Like nodular fasciitis, you may have lymphoid infiltrates. However, in fibromatosis, rather than being distributed throughout the lesion, they tend to occur at the periphery of the lesion. And mitotic figures are usually not present, but they may be seen, and they can even be numerous focally. But you should not see numerous mitotic figures throughout the lesion. So again, essentially all have infiltrative stellate extensions into the surrounding fat that you see on both gross examination and microscopically. And the ducts and the lobules tend to get engulfed, especially at the periphery of the tumor. And the surrounding breast parenchyma tends to be quiescent, so it doesn't tend to have reactive changes associated with the fibromatosis, and it doesn't tend to be proliferative. And vessels are relatively evenly distributed throughout the lesion. So here you can see, this was an example on core biopsy, and it was nice that the core biopsy actually got the edge of the lesion. So we could see that it was infiltrative at the edge here, and then you can see that most of the inflammation is at the periphery of the lesion. There is a little bit in here, but mostly it's at the edge of the lesion. And this is a nice example of the long fascicles that you see rather than the shorter fascicles that we were seeing in some of the other lesions. So as in all these lesions, the cells are strongly positive for vimentin. These also, like nodular fasciitis, are almost never positive for CD34, so that's helpful. They tend to be positive for smooth muscle actin. They can be positive for desmin and even for S100, but usually in a minority of cells. About 75% are positive for nuclear beta-catenin. This is helpful if it's positive, but if it's negative, you can still diagnose fibromatosis, since up to about 25% will be negative. And it's not entirely specific because it can be seen in a minority of spindle cell carcinomas and even in some fibroadenomas and phylloides tumors. But it still is a helpful stain if it shows nuclear positivity. So as far as genetics go in fibromatosis, it tends to be associated with activating alterations of the Wnt beta-catenin pathway in about 95% of fibromatosis at all sites, not just those in the breast. And the different mutations you see are somatic CTNNB1 gene mutation in up to about 88% in sporadic cases. You can also see somatic APC gene mutations in about 15 to 20% of cases, so a minority. And then also, as I had mentioned before, fibromatosis can rarely be associated with familial polyposis, and in this case, the APC gene mutation is germline, but this only occurs in about 2 to 8%. Mutation rates are similar in fibromatosis of the breast, although in one study they did find lower rates of the CTNNB1 gene mutation at about 66 to 78%, but still it was the majority of the cases, but they found a little bit higher mutation rate of the somatic APC gene in the breast fibromatosis. So currently at UNC, we do wide local excision or mastectomy. A recent multi-institutional study, though, with a review of the literature, found that in some cases of extra-abdominal fibromatosis, they are tending toward a watch and wait approach rather than excision. And the reasons for that is because excision outside the breast as well as in the breast can be quite morbid because you often have to do a large excision to try to get a good margin around the fibromatosis because it does infiltrate and it can be difficult to try to completely excise it. And there is local recurrence in up to about 29% of cases. And they used to think that getting negative margins really lowered the rate of local recurrence, but that is not as clear anymore. So it may not have as good an effect on local recurrence as previously thought. So these are all reasons that they're kind of shifting to possibly watching and waiting. A minority of them will spontaneously regress, but in one study, still about 30% ended up needing surgery anyway, but then the rest did stabilize, even though they didn't regress. So in this study, they also discussed other therapies for fibromatosis other than surgery or the watch and wait. Radiotherapy has been used. The main role is in patients who have progressive disease, though, and are not surgical candidates. Otherwise, they would proceed with surgery. In very severe cases or those that are rapidly progressing, chemotherapy has been used. And more recently, they have tried tyrosine kinase inhibitors in patients who do have progressive disease. There have been no completed randomized control trials yet, but sorafenib and imatinib in cohort studies have shown stabilization rates up to about 80%. So that's a pretty hopeful finding, and there is an ongoing randomized control trial of sorafenib. So that may be useful in the future. So the differential diagnosis is the fibromatose-like metaplastic carcinoma. You do tend to see more nuclear atypia and a higher mitotic rate in the fibromatosis-like metaplastic carcinoma. And also you should see at least focal cytokeratin or myoepithelial marker staining in metaplastic carcinoma, which you do not see in fibromatosis. And the peripheral lymphoid aggregates also suggest fibromatosis. One of the most difficult differential diagnosis with fibromatosis, though, is previous surgical site changes or trauma, because often when you excise fibromatosis, because it's difficult to see grossly or at surgery how far it infiltrates into the surrounding breast, they go back for margins. And of course, the new margins have all these previous surgical site changes, and it can be very difficult to tell where the fibromatosis ends and where the surgical site changes begin. So trying to tell them if the margins really are free or not. It can be helpful if the fibromatosis was positive for beta-catenin, then that can be helpful in determining, again, where the fibromatosis ends and where the surgical site changes begin. But things like fat necrosis, multinucleated giant cells, hemosiderin all favor surgical site changes or trauma. So also in the differential diagnosis is nodular fasciitis. As I mentioned before, the inflammatory cells tend to be more dispersed and more diffuse in nodular fasciitis rather than being just at the periphery. And inflammation and Fibromatosis is usually isolated lymphoid aggregates where you will often get a mixed inflammatory infiltrate in the nodular fasciitis. And you also see a higher mitotic rate in nodular fasciitis. So this is just a little chart of the different lesions that we've talked about. I won't go through this, but it might be helpful in the future. I have one of these that Dr. Rubio actually gave me, a little chart that I have up on my bulletin board that helps me with the spindle cell lesions in the breast. So just briefly, there is a lesion that is very similar to myofibroblastoma, that is a low-grade myofibroblastic sarcoma that actually does have metastatic potential, which myofibroblastoma does not. So it tends to be more cellular than myofibroblastoma. At least focally, you see cytologic atypia, and you do see a higher mitotic rate, usually up to about 7 to 35 mitoses per 10 high power fields, where again, it's only about 1 to 2 mitotic figures in myofibroblastoma. And CD35 is still often positive, but less often than it's positive in myofibroblastoma. And this does have a potential for local recurrence and metastasis. And these are just some examples. So you can see, at least focally, you should have some pretty good atypia. This one is actually a PASH-like appearance. But again, you can see that you have cells that you generally would not see in PASH. And here you have fascicular growth, which again could be in the differential diagnosis for a fascicular myofibroblastoma or fascicular PASH, but you would see, at least focally, atypical cells. And here you can see the cells are more plump, and you do see pretty prominent nucleoli. And then inflammatory myofibroblastic tumor is the other one that's in this category of being potentially metastatic. This one usually has circumscribed margins. It does not have correlation with local trauma. You do not tend to see much in the way of atypia. It's usually mild, but sometimes you can see focal severe atypia. This one has more of short bundles and that kind of story form pattern that we've seen in some of the other lesions like myofibroblastoma or solitary fibrous tumor. In this case, you see more of a lymphoplasmacytic type infiltrate that does tend to be more dispersed and intermingles with the spindle cells. And you may see macrophages or a few multinucleated giant cells, which can help you with the diagnosis. It tends to have a low mitotic rate. Rarely there can be focally more numerous mitoses. So this one tends to be positive for smooth muscle actin, and the stain that is most helpful in inflammatory myofibroblastic tumors is ALK1. Unfortunately, it's only positive in about 50% of cases, so it doesn't help you if it's negative, but if it's positive, it is helpful to make this diagnosis. Desmin and even cytokeratins can be focally positive. This is another lesion that is negative for CD34. It's also negative for S100, estrogen and progesterone receptors, beta-catenin, and STAT6. So all those stains can help you differentiate it from fibromatosis, from solitary fibrous tumor, from myofibroblastoma. And the treatment is complete surgical resection, but there is local recurrence in up to about 15 to 20%. And it's in this category because rarely it can show metastases. And this is an example. Again, you see this kind of story form pattern, but here you can see there are bunches of plasma cells that are intermingling with the tumor cells. And this is just an example of the smooth muscle actin. Primary sarcomas, very, very briefly. So as I've mentioned before, most commonly the sarcomas represent either spindle cell carcinoma or a stromal component of a malignant phylloides. And actual primary sarcomas are extremely rare, comprising less than 0.1% of malignant breast tumors. Angiosarcoma is the most common, and it can be differentiated from other sarcomas based on the vascular morphology and the immunohistochemical markers. And in a series from Mayo Clinic, along with a review of the literature, they found 25 patients who had primary sarcomas, and each of fibrosarcoma, angiosarcoma, and pleomorphic sarcoma were seen in 6 cases. There were 3 myxofibrosarcomas, 2 leiomyosarcomas, and then 1 each of hemangioparasitoma and osteosarcoma. So this shows that when you do have a primary sarcoma of the breast, it can be any type, but they hardly ever occur. And the tumor size did range up to 12 centimeters. The mean was about 6 centimeters. Local recurrence was seen in 11 patients and distant metastasis in 10. And these are morphologically similar to the extramammary sarcomas. So in summary, spindle cell lesions of the breast do represent a wide spectrum of reactive and neoplastic processes. It is critical to exclude metaplastic carcinoma, and metaplastic carcinoma does enter the differential diagnosis for both the bland and the malignant appearing lesions. Excisional biopsy may be required for an accurate diagnosis. Immunohistochemical stains may be useful if you cannot make the diagnosis based on morphology. And this is the last time I'm going to say this, but primary sarcomas of the breast are extremely rare, and malignant spindle cell lesions are more likely to represent the metaplastic carcinoma or the stromal component of malignant phylloides. And thank you for hanging in there. That is my presentation. And yes, if you have any questions, I will be happy to try to answer them.
Thanks, Dr. O'Connor, for your excellent presentation. Yeah, I have a question, and I have 2 more. I have trouble deciding is a rexine fibromatosis to, like you said, to see histiocytes or like side like section. So, do you think?
I'm sorry, you kind of went in and out, so I didn't catch the whole question.
Are you listening to me?
Yeah, I can't. You're kind of going in and out.
Okay.
Sorry.
So I have some trouble defining histiocyte or any nervous fibromatosis. You're to do to make like beta-carotene for those cases always? Or no?
It can be helpful. Yeah, the problem with beta-catenin is that it's very helpful if you have really nice nuclear staining. We find here that every time we use it, it ends up being like cytoplasmic. It isn't all that helpful. But if you have really strong beta-catenin staining, that's helpful. The other thing that really helps with fibromatosis is just that you just have those kind of more long sweeping fascicles, and it's always infiltrative. It doesn't tend to stain for like P63, which helps distinguish it from the metaplastic carcinoma.
Okay, thank you. The second is in these plastic carcinomas like a carcinoma, we should make the time graduation, or you just avoid to make this graduation in those kind of tumors?
I'm sorry, you're going in and out again, so I didn't catch the whole question.
Okay, so when you have these kind of tumors like metaplastic carcinomas, for example, a spindle cell carcinoma, you usually make the Nottingham graduation, or you just avoid to do it in these kind of tumors, like in metaplastic in general?
Oh, the Nottingham?
The Nottingham, yeah.
Yeah, on the spindle cell carcinomas, we tend not to. You can, and it's okay to do either way, but um, we tend not to on the ones that are completely spindle cell. And some of the other ones, like if it has a squamous cell component, sometimes
Yeah.
we will do the Nottingham grade. It's not wrong to do it either way.
Okay. And the other question that we have is, do you graduate the angiosarcomas? Angiosarcomas, you just graduate like low grade in,
Oh,
or is it necessary?
yeah, we do not now. Because they all act like high grade lesions. Um, and this is kind of a relatively recent change, but we no longer grade them. So we consider, if we have an angiosarcoma, we do consider them all high grade.
Okay. And the last question is, you mentioned the usage of molecular techniques for these lesions. How often it used in your daily practice, and would you say it's mandatory in any of the mentioned lesions?
No, um, we hardly ever use it. We did actually send a lesion out that looked like nodular fasciitis. And we actually even here had to send it out for a USP6 because we don't do that here. And it came back negative, and we called it nodular fasciitis anyway. So so why did we do the fish? But no, we would do it as like a last resort. But in most of these lesions, between the morphology and the immunohistochemistry, you can make the diagnosis. So even though there are some options for the genetic and molecular testing, we hardly ever do it.
Okay, I think that's all, Dr. O'Connor. Thank you
Okay.
very much for everything.
Oh, and
And
thank you
and
for inviting me, and thank you for your attention.
okay, Dr. O'Connor, thank you very much.
Okay, thank
See you.
you.
Bye.
Bye.